My name is Dr. Adam Farber, and I would like to talk today about shoulder dislocations. In order to understand shoulder dislocations, let us first talk about normal shoulder anatomy. The shoulder is a ball and socket joint, where the socket, also known as the glenoid, is part of the shoulder blade, and the ball, also known as the humeral head, is part of the upper arm bone or humerus. If the arm bone is removed and you look at the shoulder blade from the side, you can see the circular-shaped socket called the glenoid. The glenoid is labeled with the letter G in this image. Surrounding the glenoid is a circular soft tissue structure called the labrum. The labrum acts like a soft tissue bumper that prevents the ball from sliding out of the ball and socket joint. The labrum is depicted with the red circle in this image. The labrum is the main stabilizing structure of the ball and socket joint. The labrum helps deepen the socket and thus stabilizes the ball and socket joint. In addition, the labrum serves as the attachment site for all of the major ligaments that help stabilize the shoulder. Those ligaments are labeled A, B, and C in this image. This is a view of a right shoulder. The labrum is often described like a clock face. 12 o'clock is the top of the labrum, 3 o'clock is at the front of the labrum, 6 o'clock is at the bottom of the labrum, and 9 o'clock is at the back of the labrum. This is an arthroscopic photograph taken at the time of surgery. The humeral head, or ball, of the ball and socket joint is labeled with the letter H, and the socket, or glenoid, is labeled with the letter G. The soft tissue bumper resting on the edge of the socket is the labrum and is labeled with the letter L. The labrum is depicted with the dashed yellow line in this image. The red line represents one of the ligaments attaching onto the labrum. When shoulder dislocations occur, the ball comes out of the ball and socket joint. This can either occur out of the front of the shoulder joint, in which case it is called an anterior dislocation, or out of the back of the shoulder joint, in which case it is called a posterior dislocation. More than 90% of all dislocations are anterior dislocations. When an anterior dislocation occurs, typically the labrum is torn off of the socket from the 3 o'clock to 6 o'clock position on the clock face, as shown in this diagram. This is an arthroscopic photograph taken at the time of surgery in a patient who previously dislocated his shoulder. The humeral head, or ball, of the ball and socket joint is labeled with the letter H, and the socket, or glenoid, is labeled with the letter G. The soft tissue labrum has been torn away from the socket and is labeled with the letter L. The gap between the torn labrum and the socket is enclosed within the red outline. Patients with labral tears often report a sense of instability if the shoulder actually comes out of socket. This most commonly occurs with the arm overhead and behind the torso, as shown in the picture on the right. Patients may also complain of deep-seated shoulder pain. Some patients may report symptoms such as catching and painful popping in the shoulder. Labral tears can be either treated conservatively with non-operative treatment measures or with surgery. Conservative measures included the use of a sling, rest, and a course of physical therapy intended to regain shoulder range of motion and improve strength while the labrum heals back to the bone. Conservative treatment is often recommended for patients who sustain a dislocation for the first time. Surgical treatment involves repairing the torn labrum back to the bony socket of the ball and socket joint. Although this can be performed either in an open fashion with large incisions or arthroscopically with minimally invasive incisions, I prefer the arthroscopic approach. Surgery is typically recommended for patients who have sustained more than one dislocation episode. Surgery may also be recommended for patients who sustain their first dislocation at a young age, especially under the age of 25, or if they are involved in contact or collision sports, because these patients have a very high rate of recurrent dislocation episodes without surgery. Arthroscopic surgery involves numerous small incisions around the shoulder. This is performed on an outpatient basis, meaning that patients do not have to spend an overnight stay in the hospital. The surgery typically takes 60 to 90 minutes to perform. This is a photograph displaying the setup for arthroscopic shoulder surgery, with a small camera placed inside the shoulder through a small incision on the side, and a shaving device placed in the back of the shoulder through a similar small incision. The labral tear is then fixed by placing small plastic screws with sutures attached into the bone where the labrum should be attached. The screws, called suture anchors, are seen in this slide before and after they are placed into the bone. Once these screws are placed into the bone, the sutures are then passed around the labrum, and when the sutures are tied down, the labrum is pulled back down to the bone. Typically 2 to 4 suture anchors are required to completely repair the labral tear, but this depends upon the size of the tear. The image on the left is a diagram showing a completed labral repair with 3 sets of sutures encircling the labrum labeled with the letter L, and reattaching it to the bony socket labeled by the letter G. The image on the right is a photograph taken at the time of surgery showing a completed labral repair using 3 suture anchors. For further information about shoulder dislocations or labral tears, please feel free to contact my office at 480-219-3342 or visit my website at phoenixshoulderandknee.com.